everyone. First, thanks for Health for the World for allowing me to moderate this event. This is a great organization doing great work out there. I can't say enough about it. But I also can't say enough about our speaker today, uh, Dr. Erin Schwartz, amazing person, amazing speaker, and I mean, her CV's also amazing. That's probably the key word about her is amazing. So just a little bit about Dr. Schwartz. She's associate professor at the University of Pennsylvania. She is the division chief of neuroradiology at the Children's Hospital uh, in Pennsylvania. She's the editor-in-chief for Applied Radiology. She's held multiple leadership positions. Her most recent, or the one that she's soon going to be, is president-elect for the American Society of Neuroradiology, which is a huge task. I commend her for it, but she's an expert in multiple things, including the topic today. Also an expert in MEG and epilepsy in kiddos. So you're really going to enjoy everything she has to say. I know I am. And please feel free to put in the chat any questions you might have. And we also have a Q&A. I'll try to watch that. And then at the last 15 minutes of the talk, we'll probably get to that. And we'll try to have Dr. Schwartz answer as many questions as you can for you. So with that, I'll turn it over to Dr. Schwartz.
Thank you very much for that kind introduction. I'm going to share my screen here and hope that this works. And if someone could just let me know when you can see my screen, either in the chat or verbally, that would be great. Let's see.
We can see your screen.
Okay, terrific. Well, thank you. Thank you so much to everyone for the invitation. It's an honor to be here, and it's a privilege to be affiliated with the with Health for the World. I was recently invited to be the faculty advisor for the Pennsylvania chapter, and I accepted willingly and grateful for the honor. So delighted to be here and to talk about a very challenging topic, right? Abusive head and spine trauma. Here's my disclosure. As was mentioned, I am the editor-in-chief of Applied Radiology, and through that I receive funding from salary support from Anderson Publishing. We're celebrating our 50th anniversary this year, so I'll take a minute to invite everybody to head over to appliedradiology.com. Subscriptions for our digital publication are free worldwide. So please come join us. You can get free CME credits and some great content and interesting cases. So with that, here's what we're going to cover right now. Why are we talking about this? Because all-cause traumatic injury is extremely common in children, and unfortunately, abusive injury is relatively common. The diagnoses are highly reliant on imaging. Unfortunately, treatment options are currently relatively limited. How are we going to do this? It's cross-sectional imaging all the way, CT and MRI for making these diagnoses in the overwhelming majority of cases. We'll touch on radiographs a little bit. And what are we going to cover? What I want to share are features that have been shown in an evidence-based way to help distinguish between accidental injury and abusive head injury, and then also some of the unique features of the traumatized developing spine, right? So as we said, traumatic brain injury is the leading cause of death and lifelong disability in children with ever increasing incidence and costs to society worldwide. In the United States alone, more than 500,000 children sustain a traumatic brain injury every year. Now, most of these are caused by falls, typically accidentally falls. About a quarter are unintentional blunt trauma. Fortunately, motor vehicle accidents are not as common, but they do compromise a disproportionate proportion of all-cause mortality. And when we're talking about assaults or abusive trauma, it is the leading cause of traumatic brain injury related death in children under 4 years of age. It causes half of all serious or fatal traumatic brain injuries in children 2 and under. And the peak incidence of fatal traumatic brain injury is really in infants, 1 to 2 months of age. And it's extremely important that we obtain high quality images, that we interpret them appropriately, and that we use consistent terminology. And this is because the injury patterns and the subsequent treatment are highly variable, with highly variable outcomes across trauma centers, including the use of surgical decompression, the use of invasive intracranial pressure monitoring. And it's often our cross-sectional imaging features that are so important in determining whether a patient needs intracranial pressure monitoring. But these features don't get factored into many of the care guidelines. And while there are no widespread benefits in humans yet from any of the randomized control trials that have been tried for hypothermia, antioxidant administration, other neuroprotective agents, these things are coming. So it's incumbent upon us to have consistent terminology and accurate interpretation, so that we can move forward with these life-saving and neuron-saving therapies. And that's one reason why this TBI RADS was developed by the ACR Head Injury Institute. I'm not going to go into it in detail other than to mention that it's here. There's some decision support. There's some common data elements that you can use to standardize your reporting, so that you and your clinicians know what you're saying, and that you're being consistent about how you report these injuries and the features that you're using to suggest that there's abusive head trauma. So how are we going to do this? Skull radiographs are generally not indicated. They may be useful in the setting of doing a complete skeletal survey, for aiding in establishing a diagnosis of abusive trauma, especially abusive head trauma. And we can see here there's a large fracture that runs across the parietal bone in a very comminuted, complex way. As part of the skeletal survey, we may often pick up these healing rib fractures that we see, and these multiple fractures are going to clue us in that this is suspicious for abusive trauma. Now, brain CT remains the standard of care for imaging of acute accidental and non-accidental traumatic brain injury. And there are these decision rules that lots of folks are familiar with to identify which children are at lower risk of clinically significant brain injuries and maybe don't need to get scanned, right? And folks may be familiar with the PCARN, CATCH and CATCH2 and the Chalice trials, screening clinical protocols to determine if there's clinically important traumatic brain injury. They're all relatively sensitive and not particularly specific, although that's what you want in a screening protocol. However, these prediction rules 100% rely on accurate patient history, and these do not apply in the setting of suspected abusive head trauma. I want to be very clear about that. The protocols that your trauma centers are using for accidental brain injury should not be used if there is suspected abuse, or if you see features to suggest abuse on a skeletal survey or other abdominal imaging or something. Then those patients should go on to brain CT. And you want to use a nice high resolution technique. Contrast is not warranted. Remember that our axial images may miss these sorts of skull fractures that run parallel to the plane of the section, and is often the case in an acutely traumatized patient, you've got devices and things and padding and blankets and everything overlying. And so be sure to always check your scout radiograph, but know that you may miss these linear fractures when you go through them axially. So you want to take a good look at your scout. Obviously, coronal, sagittal reformations using a bone algorithm do have higher rates of detection. And it's actually been shown in patients who are 2 years of age and younger, adding 3Ds increase your sensitivity and specificity for fracture detection. Now, nobody's going to miss this depressed, comminuted fracture here anteriorly, but these purely linear or linear oblique fractures can be difficult to see on straight axial imaging, which is why at CHOP we've instituted these standard 3D reformations for all patients under 3 years of age. And I'm not going to go much into the imaging findings of, your typical epidural hematoma, your typical subdural hematoma look the same in children as what you're used to seeing in adults, and the appearances are the same whether they're caused by inflicted trauma or whether they're caused by accidental trauma. Now, brain MRI is going to be for further evaluation once patients have been stabilized of both acute, subacute, chronic injuries. Now, some authors have been advocating the use of non-sedated rapid MRI in the acute setting to eliminate the radiation from the CT. And what they've found is that MR had similar to very slightly improved, but it didn't reach statistical significance for detecting epidural hematomas, subdural, subarachnoid, and parenchymal injuries compared with CT. But overall, the detection rate for fractures was substantially poorer. And this was with standard sequences. These rapid screening MR techniques are inadequate for the evaluation of patients acutely in the setting of abuse, even when combined with CT. They've been shown to have reduced detection of subdural and subarachnoid hemorrhage when compared with standard MRIs. So I'm here to tell you that up front, the study of choice should still be, at least in my opinion, a head CT to make that initial diagnosis, and then MR can be used to further define those injuries. Your MR technique is going to be your standard workhorse sequences, T1, T2. We can see in this case this hyperintense subdural hemorrhage. It can readily identify parenchymal contusions and associated thromboses. FLAIR can be helpful for looking at these little lacerations and contusions. Diffusion weighted imaging, as we'll see, hypoxic ischemic injury can often be a feature of inflicted trauma. Susceptibility weighted imaging, something blood sensitive. So susceptibility weighted imaging can be extremely helpful for identifying these hypointense areas of hemorrhage. Some institutions also like to complement that with a coronal plane T2 star or T2 gradient echo image, which can help identify lesions closer to the vertex. And so those two may be used in a very complementary way. And so what is this all for, right? You've heard me say now a number of times, abusive head trauma. This is the preferred term over non-accidental trauma. Let's call it what it is. We're not calling it what it's not. And as we've said, in infants and young children, it is 10 to 15 times more common than accidental head trauma. And there was a relatively recent review of the literature from Tina Duhaime and Cindy Christian, both of whom I've had the pleasure of working with. And they go into some of the mechanisms, the evidence, and the management, things that we're not going to have the time to cover here, but I encourage you to review this really terrific article for if you're interested in those aspects of this topic. So let's talk about the imaging findings. In children who are 6 years of age or younger, these features have been more strongly associated with being due to abusive head trauma. And that includes subdural hematomas, ischemia, retinal hemorrhages, skull fractures associated with intracranial injury, and skull fractures that contact two or more sutures have all been shown to be statistically significantly more likely due to abusive head trauma, while epidural hematomas, scalp soft tissue swelling, and isolated skull fractures are more significantly associated with accidental injuries. And subarachnoid hemorrhage, diffuse axonal injury, and diffuse cerebral edema have not been shown to be more associated with either mechanism. Right. So if we see this constellation of findings, a patient who's got a hypodense subdural hematoma, we see, and then posteriorly there are hyperdense components. We see these areas of reduced diffusion posteriorly, retinal hemorrhages, which when they're large enough, you can even see on CT, but that's another area where your susceptibility weighted imaging on MR can be particularly helpful if they've not yet had an ophthalmologic exam that identifies those retinal hemorrhages. And then fractures, as we said, a fracture that contacts two or more sutures, much more likely to be due to abusive head trauma than accidental head trauma. Other findings associated with abusive trauma include the tadpole or lollipop sign, depending on whether you like frogs or you like candy more. And what this is, and you can see it on any of the cross-sectional imaging modalities, is direct bridging vein injury and subsequent thrombosis. And when you see this in association with a subdural collection, be it a hematoma or a hygroma, this is also a strong indicator of abusive trauma in the absence of an appropriate accidental trauma history. And so what this is the oval or rounded, this is kind of the body of the tadpole. This is the thrombotic material within the subarachnoid or within the subdural space. And then this little bent tail is the bridging vein that's been expanded by this thrombus, by this clotted blood. Typically, we see these as hyperdense to somewhat isodense on CT, T1 hyperintense, and then T2 iso to hypointense. And then on susceptibility weighted imaging, we can see, kind of that oval body of the tadpole and then that tail, and we see multiple of these. Other imaging findings that are more strongly associated with abusive head trauma include parenchymal lacerations. And in one study, they saw this in about 13% of patients with confirmed abusive trauma, but not in a single patient with accidental trauma. And this typically tends to be in younger patients. The other one are large areas of cortical injury in association with a subdural hematoma or subarachnoid hematoma in an infant. And so this is what these parenchymal lacerations look like. They can have these sort of hypodense clefts on CT. Here we see on axial T2 weighted image, this ovoid cleft-like area, different than those gyrus rectus contusions like we see in adults after motor vehicle accidents, right? This is much more well-defined, rounded. They tend to be subcortical. And again, here on FLAIR, we see suppressing and obviously in association with bilateral subdural collections, these parenchymal lacerations, very strongly associated with abusive trauma. And finally, these retroclival extraaxial, typically epidural hematomas in younger patients are associated with abusive trauma. But when you see these retroclival collections with tectorial membrane injury, that's generally with major accidental trauma, like a high-speed motor vehicle collision. However, this other phenomenon of this unilateral hypoxic ischemic injury, unihemispheric, has been reported in young children with abusive trauma, even in the absence of documented vascular or spinal cord injury. And the etiology for this is unclear. Some people theorize that it might be due to a cervical vascular compression, either from direct strangulation or from hyperflexion, hyperextension in the setting of shaking. There could be transient vasospasm. But what you see is this unihemispheric, in this case, this reduced diffusion diffusely through the white matter. And then we see this reactive hyperperfusion on, this is arterial spin labeled perfusion imaging. We see kind of a diffuse loss of gray-white differentiation throughout portions of that hemisphere in association with the extraaxial hematoma, and in this case also in association with retinal hemorrhages. So this constellation of findings would be very, very suspicious for abusive trauma. And so one of the things that we get asked a lot about is the timing of these injuries, particularly by our child abuse and neglect team, if they're going to try to determine when this injury occurred, to help them determine who caused the injury. They'll often ask about timing, and it becomes extremely challenging. There aren't great hard and fast rules, but we do have these charts that have put together based on the literature, noting that there's a fair amount of overlap. So the general evolution of a subdural collection on CT, note that in the hyperacute and acute stage, which is, from a couple of hours to about a week and a half, these can actually be mixed. And these mixed density hematomas are actually more common than uniformly hyperdense or isodense hematomas, and can even be seen within several hours of injury. And the thought is that either there's prior injuries, or you can have a mixture of serum, clotted and unclotted blood, and CSF, right? This hematohygroma concept. So the idea that when you see a mixed density hematoma, it automatically means it's of varying ages, has not been borne out to be factual. So remember that these early lesions can be mixed, and then they become progressively more isodense. Similarly, on on MR, we move through from hyperacute to acute, early and late subacute, and then chronic changes, but there's a lot of overlap in these timings. So what I tend to tell our child abuse experts is, we can just put you in this range, but you'll see that like the acute is 1 to 4 days, but the early subacute is 2 to 3 days. So there's a lot of overlap in any of these features. And the flare signal intensity findings have not been as consistently proven as the T1 and T2 changes. And that when you do have sedimentation of blood products, the signal from the sediment is felt to be more accurate for timing, especially on T1 and T1 and flare. The other important thing to remember is that all of these criteria were developed at 1.5, and it remains to be seen if they're going to be equally applicable at 3T. So that's work that continues right now. But these generally can help you. So unfortunately, this is the sort of thing we're going to see. Global lost gray-white differentiation, the so-called white cerebellar sign. We see subarachnoid hemorrhage. We see interhemispheric subdural hemorrhage. There's scalp soft tissue swelling. We see a depressed fracture. And then going to MRI, we see this marked abnormal hemorrhage within all of these areas of hypoxic ischemic injury and marked traumatic brain injury with lots of soft tissue hematoma. A really horrible case of abusive trauma. And remember that spinal injury in abusive head trauma is somewhat overlooked. And we're going to go in detail into the spine, but I wanted to present it here because there are recommendations about what you can do if you've got brain imaging and you're suspecting abusive head trauma. We're going to remember that cervical spine ligamentous injuries, especially nuchal, as well as atlanto-occipital and atlanto-axial, are present in the overwhelming majority of patients with abusive head trauma. They're less common in accidental trauma, and we almost never see them in non-traumatic injuries. And that they're very highly correlated with hypoxic ischemic brain injury, with abusive head trauma, and with cervical spine injuries. And so that led several authors to conclude that it may be this transient high cervical spinal cord injury that leads to disordered breathing and results in the hypoxic ischemic encephalopathy. But this is just a theory. And so, recommendations when you have documented or suspected abusive head trauma, offer different authors have different recommendations. The group from New Moors had suggested that MRI of the entire spine be performed, while the group from Atlanta has suggested that MRI of the cervical spine should be performed in all cases of abusive head trauma, and importantly, also strongly considered in children where you've got acute intracranial hemorrhage and an otherwise non-contributory history and physical. And that may help you distinguish traumatic from non-traumatic causes of intracranial subdural hematomas or subdural collections. So to summarize the findings in our traumatic brain injury patients, the features that are more likely associated with abuse head trauma include subdural hematomas, ischemia, retinal hemorrhages, fracture with intracranial injury, fractures that contact more than two sutures. When we see unilateral ischemia, especially in younger patients, that tadpole or lollipop sign, especially in association with one of these other findings, parenchymal lacerations, retroclival extraaxial hemorrhage, and when we see large cortical injuries in infants. Those that are more likely to be associated with accidental trauma include epidural hematomas, scalp soft tissue swelling, isolated skull fractures, and when we see retroclival epidural hematoma associated with tectorial membrane injury. And subarachnoid hemorrhage, diffuse axonal injury, and cerebral edema are all non-specific findings. But to further emphasize that, it's actually been shown that combinations of intracranial injury with fractures, especially multiple fractures, with retinal hemorrhages, and with characteristic clinical features, which include apnea, head or neck bruising, and seizures, can actually have a positive predictive value for diagnosing abusive head trauma that approaches 100%. So you can feel confident about making the diagnosis when you see these constellation of features. So what's your diagnosis here? Unfortunately, in a virtual format, it's tough to be, as interactive as I would like to be. But here we see the brain of a young child. We have these large subdural collections with some mixed density, right? Especially over the left frontal lobe. We can see this sort of hyperdense layering area. On fat suppressed FLAIR images, we see these bridging veins stretched across these large extraaxial spaces. And then we can see this hyper intense signal within that left sided collection. On the parent diffusion coefficient map, we have these areas of reduced diffusion over the temporal poles, over the anterior frontal lobes, scattered areas within the basal ganglia, and then also up over the convexities. On susceptibility weighted imaging, we see multifocal areas of hemorrhage. Again, we see lots of these stretched and dilated bridging veins, and then focal areas of parenchymal hemorrhage as well. But remember that we always have to take this in clinical context. Contrast administration showed diffuse leptomeningeal enhancement, and this was actually a patient with group B strep infection. So remember that while we're looking for all these features, not everything that is more dense or more hyperintense as CSF is blood. You certainly can be worried about purulent materials, and everything has to be taken in the appropriate clinical context. Okay, So let's move down to the spine, where quite honestly, things get a bit more complicated. And it's important because spinal column injuries in kids are relatively uncommon. But when they do have spinal cord injury, their fatality rates are far greater than what we see in adults. Um, and even younger children have significantly higher mortality following spinal trauma than older children. While thankfully a small percentage of this is actually due to abuse, most are from motor vehicle accidents or from sports injuries. A small percentage of abusive fractures are vertebral, but they tend to be pretty significant. And so we're going to review some of these patterns because whether it's abusive or whether it's accidental, the patterns of injuries in infants are different than what we see in young children. The patterns of injuries in young children are different than what we see in older children. And all the patterns in children are different than what we see in adults. So let's start with the synchondroses, right? At birth, we have these non-ossified neurocentral synchondroses present throughout the entire spinal column, and they separate the ossification centers. At the C1 level, we see these in the anterior arch, in the posterior arch, and between the arches. At the C2, it gets even more complicated where they're between the arches and the body, between the arches, between the body and the dens. There's hypodense lines on CT all over the place. And from the C3 level inferiorly, they're going to be between the arches and the body and between the arches posteriorly. And they show up as these lucent linear bands on CT and as low intensity linear bands on T1 and T2 on MR. And they disappear earlier on MR than they do on CT. And this gets back to the importance of having to understand the normal appearance before you can confidently make diagnoses of abnormalities, right? So these charts like this, I love to print out and just slap on the wall in the reading room so that everybody can have a look at and making sure that they're not mistakenly calling fractures or abnormal osseous development. And so all of these ossify throughout childhood. The most complicated one, though, is the anterior arch of C1. And remember that when you're doing CT in kids, that superior odontoid ossification center doesn't even show up until kids can be even 6, 7 years of age and doesn't fuse to the remainder of the odontoid until even into adolescence. And so you don't want to be mistaking that for an area of traumatic injury, right? So in a young infant, we have these ossification centers, which are widely separated by these large synchondroses at the C1 and C2 level, and from C3 inferiorly, right? Here's the odontoid ossification center and the central body ossification center. But note that we don't have any ossification in the anterior arch of C1 at this age, but there is going to be a ventral cartilaginous band that's there that's helping hold everything together. And then at about 3 months of age, still not much in the way of ventral ossification. And we can see that these synchondroses are starting to get a little thinner, starting to come a little closer together, but no odontoid ossification center yet, no anterior arch ossification center yet. And look at all of the numerous synchondroses in the C2 body, right? So about 9 months of age, we start to see some of these ossification centers developing mineralization in that ventral cartilaginous area, and we start to see that hyperdensity on CT. And this article points out, though, that there's a tremendous variation in the development of the anterior arch of C1. And I think this persistence of the anterior midline synchondrosis is the one we see most frequently. I would encourage you when you're reading head CTs, make sure you take a look at that. I think you'll be surprised at how often that persists. But you can have numerous ossification centers with accessory synchondroses. So you don't want to be mistaking these for fractures. You're going to look to show that they have that nice sclerotic margin, right? At 12 months of age, we're becoming progressively more ossified. The synchondroses are getting more narrowed. And finally, at about 6 years of age, most of these are not visible on CT anymore. But again, note we still don't have ossification in that superior odontoid center. You don't want to mistake this early little ossification for some kind of fracture or um, desiccation here, because children at this age also still get fractures, and so we don't see the sclerotic line, we see the sort of abrupt lucency across the C2 level in this hangman fracture. We see the obliquity, we see the cortical offset, but no superior ossification center in this 6-year-old with a hangman fracture. But more commonly, what we're going to see in kids is the so-called skiwara, right? The spinal cord injury without radiographic abnormality. The description that I like better, I think came from Andrea Rossi's book, is spinal cord injury without evidence of vertebral fracture or misalignment on plain radiographs and CT. The acronym becomes a mouthful, but it's a more accurate description of what we're seeing. And we see this because the pediatric spine is relatively hypermobile, right? We have this laxity of ligaments and capsules. We have cartilaginous end plates and more horizontal orientation of our facet joints. And this allows, in his words, deformation of musculoskeletal structures beyond physiologic extremes with direct spinal cord trauma followed by spontaneous reduction. And this ligamentous laxity is most pronounced from the occiput through the C2 level. And remember that especially in infants, they have relatively large heads and poorly developed paraspinal muscles. And so that in constellation with all of these other morphologic findings, results in this relatively hypermobile upper spine. And remember, you can also have spasm or occlusion of anterior spinal or radiculomedullary arteries. So what does this mean beyond physiologic extremes, right? How do we get injury? In neonates, beyond physiologic extremes often means a distraction type injury, which you can get from shaking, from a rapid hyperflexion, hyperextension type injury, because that large head rotates forward and gives you a distraction of the column. Except the neonatal spinal column itself, the osseous structures, the ligamentous structures, can be stretched 2 inches, about 5 centimeters, without any structural disruption. However, the spinal cord itself will rupture after being stretched by only 1/4 of an inch, or a little more than 1/2 centimeter. And so that you can have, as we see in this case, spinal cord rupture, transection, marked spinal cord injury with an intact spinal column. We see some posterior edema, we see edema in the posterior ligamentous structures, but the osseous structures are completely intact. Here's that intact tectorial membrane, but we have a devastating spinal cord injury. And similarly, we can see axially that oblique transection right across the spinal cord parenchyma, resulting in a devastating spinal cord injury. And we can follow this as it evolves. There's barely a thread of spinal cord left, and lots of edema and injury persisting in myelomalacia distal to that area of injury on follow-up. Now, in a little older children, what beyond physiologic extremes means is when we have these epiphyseal plates in the vertebral bodies, they start to fuse at about 8 years of age. And again, that synchondrosis, the dens and the C2 body around 8 years of age. Our facet joint angulation becomes increasingly vertical as that ossification progresses between 7 and 10 years of age. But we can see dislocation and subluxation without fracture. We can see ligamentous avulsions and epiphyseal or growth plate separations. And remember that as children age, the fulcrum of motion in the cervical spine moves distally. So in infants and young children, that center of motion is going to be in the upper cervical spine, C2, C3. Kids at 5 to 6 years of age, it's going to be more upper central C3-4 level. And then by about 15 years of age, it moves toward the lower cervical spine, which is the more mature pattern where you typically get your injuries, right? And so again, just that normal, we can see the progression of that in the 2-year-old, those relatively horizontal facet joints and pretty persistent synchondrosis. By about 4 years of age, we're starting to see those synchondroses decrease and the facet joints are becoming increasingly horizontal. And then by here, this example, 9 years of age, we have complete fusion with incorporation of that superior ossification center. And then the more appropriate adult looking orientation of the facet joints. And so I've shown you a lot of CT, but I want at this point to take a step back and talk about making sure that we are incorporating our image gently techniques and imaging the cervical spine in patients in a way that's appropriate for their age and for their injury. And so a number of studies have been done to evaluate the role of CT versus plain radiographs for cervical spine injury in children. And what most of these authors have found is that CT is associated with significant exposure to ionizing radiation. No surprise to any of us, although the long-term effects of that are not entirely clear. But in this case, does increase excess relative risk, at least for thyroid cancer in young children, if we're radiating the entire cervical spine. And so what they found is that CT, even with relatively modern lower doses, exposes the thyroid to 90 to 200 times more radiation than even doing multiple conventional radiographs. But if you look at some of these decision tools, what folks have found is that, again, these screening radiographs, when we're trying to so-called clear the cervical spine, are these preferred strategies. Rarely we're going to use CT for initial evaluation. And actually, a single lateral radiograph alone has been shown to be very sensitive for cervical spine fracture detection with some age dependency. And actually adding that anterior posterior view, the additional value of that is unclear. And the open mouth odontoid view, typically you can't even get it in a young child or their teeth are overlapping. And certainly oblique radiographs don't add any significant diagnostic information. So most institutions now are just doing that single lateral radiograph that can give you a high sensitivity for fracture detection in children. And similarly, flexion extension radiographs have not been shown to offer any additional information when AP and lateral radiographs are normal or only show a straightening of the normal cervical lordosis. However, they may be useful to follow up ligamentous injury that's been documented when there's known instability once those patients are in outpatient care or undergoing rehab. Right, so for CT, the current evidence does not support use as screening tool. However, focused evaluation can be very valuable, like covering skull base through C2 to clear that area that's more likely injured in these lung children. And it's actually been shown that performing CT early in the ED stay of children is associated with a longer length of stay, higher resource use, and then obviously higher increase in radiation. And so minimizing the use of CT, primarily relying on lateral radiographs, again, is very sensitive and has a very high negative predictive value for clearing fractures in the cervical spine. And then MRI may be warranted in the emergency setting if you have a patient with a progressive neurological deficit. It's obviously going to be the modality of choice for spinal cord assessment, soft tissue assessment, and actually using MRI in obtunded children for clearance of the cervical spine to be able to remove that cervical spine collar was actually shown to save almost $8,000 US in decreased immobilization time and overall decreased length of stay. So spine MR can be very helpful in these children, often not in the acute setting, but once they're stabilized, to get that collar off. So what injuries do we see in the spine? They can involve the vertebral column, the spinal cord, extraaxial hemorrhages, paraspinal soft tissue injuries, as we saw, and even help detect extraspinal injury when you're doing spinal column evaluation. So we can have vertebral compression, fractures. Very often that's an axial load mechanism or a hyperflexion mechanism. The abuser is holding the young child and slams them down on a surface, and you get an axial load and hyperflexion injury, as in this case where there's a fracture dislocation with posterior widening and lots of posterior edema and spinal cord injury. And then we can also, in this case, see an axial load or hyperflexion injury here with compression at C4. And note that this is a former premature infant, and we know that those patients are at even further increased risk of being abused by their caregivers. Now, spinal cord injuries, much like accidental trauma, again, we can see these transections. We can see spinal cord compression, and we can see conus, particularly the conus. We can get these areas of contusion, often in the absence of osseous injuries, but in this case, we can see hyperintense compression fractures here at T7 and T8. Now, remember also to look for that intraspinal extraaxial hemorrhage. It can come down from the posterior fossa, as we see in this case, a patient with a large posterior fossa hematoma, and then we see hemorrhage tracking down into the spinal canal, again with an acute fracture in that C-spine, and you can see the extension of the extraaxial hemorrhage down into the dorsal spinal canal. This can also be primarily spinal, as we see in this case in a 2-month-old. Again, no evident osseous injury, but we see this very extensive hematoma extraaxially, effacing the subarachnoid space, in this case, fortunately, without any evidence of spinal cord injury. And also paraspinal soft tissues, as we've mentioned, can be a clue that when you've got an intracranial subdural hematoma, especially in the setting of diffuse global hypoxic ischemic insult, doing that associated cervical spine imaging or doing that complete spine imaging can show you these additional areas of injury that can help confirm the etiology for your intracranial findings. And finally, remember when you're doing your spine imaging to look outside the spine, outside the central nervous system. Other features that are highly specific for abusive trauma include associated skeletal fractures, especially when multiple. In this case, we also see a fracture of the medial clavicle, and when you have associated visceral injuries. So in this case, we see a hepatic laceration and pancreatic lacerations in association with our T2 spinal process contusion and overlying soft tissue injury. So this constellation of findings, especially an acute fracture with a healing fracture, highly specific for abusive trauma. And similarly, again, when you've got your coronal spine imaging, which we really like for trauma, make sure that you're looking, in this case, the obvious intra-abdominal fluid, the lung collapse, and then on CT, you could see numerous healing rib fractures, and then a very typical healing metaphyseal corner fracture. So the constellation of findings, very specific for abusive trauma. And I just want to remind you that post-traumatic spinal cord infarction is an entity that's somewhat unique to children and even adolescents, excuse me, even after relatively minor trauma. And these signs can be discrete from the time of the injury, developing even days to hours post-injury, paresis and a dissociated sensory loss being the two most common finds. And the theory is that the nucleus pulposus embolizes into the spinal cord microcirculation. And that typically this involves the anterior spinal artery territory, and that you have this T2 prolongation in the anterior 1/2 to 2/3 of the spinal cord, or the ventral gray matter. And this is not an abusive trauma situation, but a sibling trauma. This is a teenager whose sister walked on his back, and later and into the next day, he became progressively weak. And we can see this abnormal T2 prolongation in the ventral spinal cord, and here ventrally within the gray matter on axial, and on diffusion weighted imaging, we see that reduced diffusion within the ventral gray matter. And on follow-up, it takes on that typical appearance of this focal myelomalacia, an axial, that classic sort of snake eyes appearance of a spinal cord infarction. So in summary, we know that little spines are not like big spines. We know that the spinal cord rupture can occur well before spinal column failure. You want to use lateral radiographs with focused CT. When you can't clinically clear the patient, screening CT is not appropriate. MR for soft tissue and spinal cord injuries. And remember post-traumatic spinal cord infarction in children, and do those spinal MRs when you've got findings of abusive head trauma. And I just put this up again if folks want to do a screen grab. I know we've reviewed this before, but these are the features that are more likely associated with abusive trauma when you see them in children. And remember that combinations of injuries have a very high predictive value. I also wanted to take a moment to thank the organizers again for inviting me, and also call attention to the fundraising efforts that Health for the World is doing right now to provide oxygen concentrators for our siblings in India who are being so devastated by COVID-19 right now. So I encourage you to make a donation. No donation is too small. Please go to healthfortheworld.org and help out if you can. And with that, here's my Twitter handle. You can follow me there and find me there. Thanks for the invitation, and I hope you all enjoyed the lecture.
All right. Thank you so much, Dr. Schwartz. Like, as I predicted, that was amazing. I think every time I listen to one of your talks, I always learn something more, and that is just great. We do have a couple of questions in the question and answers, and if anyone else has any questions and answers, feel free to type them in the box, and I'll try to get to them within our limited time. The first question I have here is, do you recommend brain ultrasound in little children to avoid radiation days after trauma?
It's a good question. I mean, obviously the radiation issue is one that we still have a lot of questions about. There's more information coming out every day. In fact, some recent work came out saying low dose radiation is actually beneficial to the brain, and in adults actually shows improved function in Alzheimer's patients after repeated low dose CT. We don't understand the radiation story, I think, is the bottom line. Brain ultrasound obviously can only be performed in young children. I think it's valuable if you have a documented injury and you want to do something non-invasive like follow ventricular size. If you have a concern their head circumference is going up and you want to know if they're developing hydrocephalus versus enlarging collections. But again, remember, ultrasound is not only very operator dependent, but you're really restricted over the convexities in what you can see. And so it's very challenging to identify those subdural hematomas that are so common in our abused children. So I think has limited utilization. People have used it from time to time to look for if you've got a fracture that overlies the sinus, and you want to see if, especially the superior sagittal sinus, if you want to see that that's patent, that's where doing Doppler sonography can be helpful. If you have a situation where the patient's not stable enough to go to MR, or you're really, not suspicious, but you just want to quickly rule it out, that's where it can be helpful. But I think otherwise, ultrasound has a pretty limited role in this setting.
Perfect. Yeah. I know also with CT, there's a lot of new techniques that we can really reduce the dose of radiation, so it becomes less and less of a concern nowadays. And I think you have to always do what's best for the patient as far as getting the clinical answer too. We can't not get the clinical answer just to spare a little bit of radiation.
Absolutely.
The next question, you sparked someone's interest when you started talking about TBI-RAD, and they wanted to know a little more about that.
Sure. Yeah. I mean, it's one of these things that we could talk about traumatic brain injury for 6 hours and not cover everything. So TBI RADS is a initiative through the Head Injury Institute and the American College of Radiology. I would encourage you to go to their website, Head Injury Institute. You could Google ACR TBI RADS. It's some of it is developing standardized reporting, common data elements to make sure that we can do the necessary research, that people can do meta-analyses across numerous papers, because one person's calling it a subdural collection and another paper calls it a subdural hygroma and another paper calls it a subdural hematohygroma, and trying to gather all that into one consistent, to be able to do meta-analyses, to be able to draw broad conclusions about this. It makes it extremely challenging. I mean, if you look at the paper from 2014 where they tried to go across all of the different studies that have looked at the timing of CT and MR, the descriptions are so across the board, it almost makes it impossible to generate any usable data. And so that's their goal. But I would encourage you to go to that website to check out more.
Perfect. And we do have another question, and it was something I was kind of thinking of, and it's the thing that we don't want to necessarily think of, but it's out there, especially in the US, legal issues. So there's a question saying, is it safe to make the assessment to say abusive head trauma, considering the medical legal implication?
Yeah, I think that it's a great question. And I think that's why I'm trying to put the emphasis on those features that have been shown in an evidence-based way to be more highly associated. And I think that's the way you can say it in your report, and that's the way you can communicate it to the providers caring for that patient. Is, if you have a case that has subdural hemorrhage and you see retinal hemorrhages and you see a fracture that connects two sutures, you can say that those findings in the constellation of those findings have been shown to have a positive predictive value for abusive head trauma that approaches 100%, right? And then you are objectively stating what the evidence shows. Then the people who are caring for that patient can put it in their clinical context to start to evaluate, then maybe that prompts them to do their skeletal survey, and then they find healing rib fractures, which adds even more evidence in that column, as if we need it. But I think that's where using this very evidence-based approach, or if you have a patient who just has a subdural hematoma, you could say, that subdural hematomas are known to be more commonly associated with abusive trauma than accidental trauma, but that this is not pathognomonic, and that you recommend spine imaging to look for additional features that may support either an accidental or abusive mechanism, right? And so that's how you can approach it without delving too far into the legal side of things, but providing the care team with the information they need to appropriately care for the patient.
Yeah. Again, there's a patient at the end of the day there, and you have to take care of what's best for them. And if you're seeing those signs, like you said, that you point out really well, that are pointing towards that abusive head trauma or just abusive trauma in general, you still need to say something. You might have to come down and say, I'm 100% nothing else, but say these findings support it. Please look for other findings to help build your case, because we need to protect those patients.
Yeah,
So,
and oftentimes we may be the first people to think of it.
right.
You know, or you've got access to prior imaging. I remember an instance where the team didn't know that the patient had been there 4 months before with another so-called fall, and that the family had actually told the providers that this was the first time the patient had had an injury like this, and we were actually able to show that that was untrue, and so that prompted a more appropriate workup.
Yeah, yeah. And unfortunately, it happens more than we think too, or more that we want to think about. We see it here in New Mexico. It just happens, and again, we have to take care of the patient. They're the ones that we need to think about. So it is the top of the hour, 9 o'clock. Again, thank you so much for giving this talk today. I already see lots of comments in the chats. Everyone's just saying excellent lecture. Thank you so much. Fantastic talk. Again, thanks for Health for the World for allowing me to moderate, allowing Dr. Schwartz to talk about this. And like she said, please contribute if you can. Donate to Health for the World to help our colleagues out in India. All right. So I want to thank everyone.